Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an unconditional independent educational grant from Case Farmaceuti Society per Azione.
This program is presented by Medscape Education Global.
Welcome, everybody. Thank you for connecting. Over the next 20 or 30 minutes, we're going to have a great conversation related to inhaler and inhaler devices. So I'm Omar Osmani. I'm Professor of Respiratory Medicine and Consultant Physician at Imperial College London, Royal Brompton Hospital and St Mary's Hospital London in London, UK. And the programme is titled From Prescription to Practice in Respiratory Disease, Overcoming Barriers to Inhaler Adherence and Compliance. We'll be talking about inhaler devices, we'll be talking about how to use them correctly, and we'll be talking about patient perspectives in terms of what factors we should consider for our patients when prescribing inhaler devices. So I'm really delighted that I've got Amy Chan, who's Associate Professor at the School of Pharmacy, the University of Auckland in Auckland, New Zealand, and also Tonya Winders. Tonya, who's the President and CEO of the Global Allergy and Airways Patient Platform. So the three key things I think we're going to all talk about are inhaler devices, the options we have, and how to use them well and tell our patients and engage with them on how to use them well. The impact of incorrect inhaler use and the impact that has on our patients, and also their ability to get the best out of the drug that's in the device. And then factors that contribute to choosing the appropriate inhaler. And I think Tonya's going to really give us some insights from the patient perspective, and then we'll try and sort of marry that with Amy's clinical experience in terms of linking the device to the patient and incorporating patient preferences. So let's really kick off. Amy, can you take us through the inhaler choices that we have to prescribe for our patients? We, as clinicians, pharmacists, physiotherapists, nurses, as doctors, we get overwhelmed with the multitude of devices, but it is quite straightforward, isn't it?
Absolutely. I mean, when you see all the different colors of devices, you'd think, oh, wow, there's so many different devices out there. But actually, if you think about it broadly, the different devices fall into 5 categories. And I'll cover each of them in some detail. Firstly, we have dry powdered inhalers. These allow you to have the medication that is in a dry powder form, but for it to be activated from the device, you need rather rapid and forceful turbulent energy. So when the patient takes this dry powder inhaler, they need to actually try and get the powder formulation into the appropriate particles for lung deposition. So for that to occur, they actually need to take an appropriate breath for them to actually take their dose. And dry powdered inhalers don't actually have a propellant, which is why it doesn't need much coordination, which is one of the benefits of dry powdered inhalers. But because it doesn't have a propellant, you do need the patient to have the appropriate inspiratory flow to be able to get the dose into the airways and into the lungs. Because it's also a dry powder inhaler, it is quite sensitive as well to moisture, and you do need to prime it for it to work. In contrast, one of the most other common inhalers that we see is probably the ones that most of us are familiar with are pressurized metered dose inhalers, or PMDIs. And you'll see on the slide as well that we have put PMDIs with a second device called a spacer. And often the two should be used together. And that is because, unlike the dry powdered inhalers, the metered dose inhalers comes with a propellant, which helps propel the appropriate aerosol into the lungs. But because of the propellant and the way that the aerosol is released from metered dose inhalers, you do need a spacer so that it doesn't require the active coordination and you don't lose the doses from the aerosol inhalers, which can occur without the spacer. So for the best lung disposition from the PMDI, we recommend using it with the spacer to minimize the amount of coordination that is required. But because of the propellant, there has also been some discussion around the use of inhalers and whether this is the best choice depending on what propellant is used in the inhalers. Also, because of the propellant, some patients may have something called the cold freon effect, which when they take the inhaler, they may feel this effect from the propellant, which can also affect the inhalation. And some people can have a bit of a cough reflex after taking the metered dose inhaler, which is something else to consider for our patients. And then in the fourth category, we also have soft mist inhalers or SMIs. With this is a different technology, which is where mechanical energy is used to force the drug solution through the nozzles and produces these liquid jets that can collide to create a slow moving aerosol cloud. Because as a soft mist inhaler, it doesn't require a lot of coordination and it doesn't involve a propellant. However, we don't have many medications that come as a soft mist inhaler. Based on that, though, we don't see a lot of soft mist inhalers, but where it is used, it is very effective. And last but not least, I'd also like to highlight the importance of nebulizers. Nebulizers are also very important for some patient categories and can be used as an alternative to any of those inhalers in some diseases. And also some patients may prefer using the nebulizers over the other devices.
Brilliant, Amy. Thank you so much. That was really clear in giving us the variety of the inhaler devices, metered dose inhalers, the device does all the work, dry powder inhalers, the patient has to do the work, nebulizers, spacers, another device, adding onto the device, and soft mist inhalers, which are slow inhalers. So the impact, though, of incorrect inhaler use is quite significant. So can you just take us through your recommendations very much in terms of getting it right for our patients and getting it right for the management of their airway disease?
Absolutely. So inhaler misuse is actually really, really common in terms of having incorrect inhaler technique. And often I have titled in here in the slide that actually very small impacts can have very large clinical effects. And for example, we know that incorrect inhaler technique can lead to the medication being deposited in the throat or the oropharynx area instead of reaching the lower airways, which is where we really want the medication to be. And we really have to think about this because in terms of clinical outcomes, we know that evidence shows there is a direct correlation between these critical errors that we might see. And it can be as simple as, poor coordination or poor timing, or maybe they're not using spacer devices with metered dose inhalers, or they just don't have the right inspiratory flow rate, for example, to be using a dry powder inhaler, but that's the device that they have been given. So really it's around matching the right device to the right patient. And without the correct matching, we would often see increased exacerbations and flare-ups, and people with poor technique often admitted to hospital more commonly or have more frequent courses of oral steroids. So you may see this in your practice. If a patient is coming to you more frequently with a lot of courses of oral steroids, or you notice that they have a lot of hospitalizations or just poor control of their asthma or their COPD, it is worth definitely checking the inhaler technique. We also know that often there is a cycle where therapy is stepped up because of poor symptom control, but actually the real issue may be the delivery of the medication rather than drug efficacy. And importantly as well, often omitted in terms of understanding the impact of poor inhaler technique is there's actually a huge economic impact as well. I've already discussed around the impact on hospitalization and emergency department visits from people who may have poor inhaler technique, which could simply be resolved by optimizing the inhaler technique. But there is also a lot of wasted medications. So we know that inhalers are a very specific and unique medication category because a substantial portion of its efficacy really depends on the way that the device is used. And if the medication is not used appropriately, it leads to poor medication delivery. And we know that leads to substantial wasted medication and increased cost because, for example, patients may be going through lots of canisters of different inhalers because they're not just getting sufficient doses from this one single actuation or one single puff. And so really in our practice, we do see actually a lot of impacts and potentially from, wasted medications or multiple dispensings or stepping up with therapy when that may not necessarily be needed.
Amy, that's really, really helpful. So, very much that we need to spot incorrect inhaler technique and try to address it because there are big impacts from these very small errors that our patients undertake or we may not recognize. So, if I just move a little bit further, could you just give us some insights then on the current global recommendations in terms of what they say regarding the choice of appropriate inhalers from a healthcare professional perspective? And certainly, I'm going to ask Tonya really from the patient perspective a little bit later. But what do the directives, what do the recommendations say?
The GINA and GOLD recommendations are quite well aligned in identifying that the best inhaler is one that the patient wants to use. There's no use of recommending an inhaler that the patient simply will not use. So really one of the key points really I want to highlight around the recommendations is the importance of a shared decision-making cycle. And both of the recommendations from GINA and GOLD highlight that importance of having that shared conversation and being able to discuss the pros and cons of the different devices and coming to a shared conclusion and agreed decision around inhaler selection. But then when it comes to what we want to consider in terms of the recommendations is what comes down to two parts. Firstly, we want to consider coordination ability. So a patient cannot coordinate the actuation with an inhalation, which is most common with metered dose inhalers. Then the recommendation suggests that you want to definitely either use a spacer, consider whether a spacer is appropriate, or you may then want to switch to something that does not require the significant coordination, such as a dry powdered inhaler or a soft mist inhaler. The other important part that the recommendation suggests is around the inspiratory flow. So we know both the GINA and GOLD notes that some patients may not be able to generate sufficient inspiratory flow to use dry powder inhalers. In some examples you might see in patients might be children that may be too young if their flow is too weak, older patients or people who have very severe uncontrolled symptoms or severe flare-ups or exacerbations, in which case a dry powdered inhaler may not be the appropriate choice. In such cases, a metered dose inhaler with a spacer is the best option in terms of having lower inspiratory flow requirements to achieve maximal drug delivery. The other important thing is around, and I think Omar talked about it, is around ensuring that with the multiple devices out there, we try and reduce device confusion. So there is clear recommendations around the importance of consistency. So GINA and GOLD also suggests that where possible, we want to use the same device type for both the patient's maintenance and their rescue or reliever therapy where possible. So really having that fine balance between what the patient wants, what is the best device for the patient in terms of what they can physically do in terms of the inspiratory flow, and also what they can do in terms of their physical coordination and their cognition and dexterity in terms of using the device. Those are all key considerations that come from the recommendations.
Amy, that's really great. Thank you very much for synthesizing and really in a very pragmatic way how we can translate the directives and the recommendations into our everyday clinical practice. And you've talked us through the devices. You've talked us about incorrect inhaler use. You've talked about shared decision making. So this is a great opportunity now really for me to turn to you, Tonya, really from the many years that you have interacted with patients, led groups around patients and respiratory elements, and particularly with inhalers. Can you just give us insights really on the patient experience with inhalers? What is it that they really want? Sometimes we healthcare professionals, we think we know what patients want, but what is it that they really want from their inhaler device, Tonya?
Thank you, Omar and Amy. So, what do patients truly want from their inhaler? Well, first of all, we know that patients are people just like you and me. And so they want to get on with their lives. They want an inhaler that actually works, that keeps their symptoms controlled, and keeps them out of the ER or hospital and doing the things that they want to do and love to do. And yet, we know that greater than 70% of patients actually don't use their inhalers correctly. So, it has to be a simple regimen with an easy to use device. What this often means is that it's one single inhaler, not two or three. And it's preferred to have one time per day. Again, not two or three. And so, having that inhaler that number one works, that doesn't have side effects, that number two is simple to use, is very important. And then the third preference is one that's also very important, and that is one that limits their out-of-pocket expense. If we see an inhaler costing more than $25 to $50 per month, it truly impacts adherence, and people simply are unwilling to pay.
That's brilliant, Tonya. And I'm going to come back to you, Tonya, a little bit further on patient elements, but you talked, Tonya, about the inhalation maneuver. And I know, Amy, you've done work on the inhalation maneuver for a good few years. You've also looked at digital elements. So can you now just talk to us about a suboptimal inhalation and really how that affects our patient and therefore the importance of the inhalation technique, that process of inhalation? Please give us some insights, Amy, on that.
As you mentioned, Omar, actually inhalers are quite a complex device in terms of from a drug delivery perspective, and that can lead to suboptimal inhalation in a variety of ways. And when it comes down to breaking it down to different steps, we want to think about the actual physics of the device, which we touched on. Depending on the device, how is the drug actually released from the device and how does it get to the patient? And then when it gets to the patient, what happens in terms of their physiological capacity in terms of being able to inhale the dose, and then obviously some of the anatomical barriers of the respiratory tract itself. So let me break down some of the considerations. So I think when it comes to suboptimal inhalation, we might want to think about how the device actually releases the medication. So again, we've covered with dry powder inhalers, it is patient powered. It really depends on the patient being the power source and be able to actually release the medication, and that it must be broken down in terms of the powder that exists in the dry powder inhaler. The patient needs to have appropriate inhalation or appropriate suck for it to be broken down into the appropriate tiny particles, and the drug essentially deaggregated to reach the lungs with dry powder inhalers. But in contrast with metered dose inhalers, because there is a propellant, then it's very much inhaler powered rather than patient powered. So that's the first step when we think about the physics of the device. Then comes down to the actual inhalation. So for a suboptimal inhalation, we want to think about something called inspiratory flow or peak inspiratory flow. So in general, as a rule of thumb, we're really looking at a minimum of around 30 to 60 liters per minute in terms of the threshold flow. And when that flow is reached, then a drug can be released, and we consider that deaggregation can be complete. But if the inspiratory flow is below that threshold, what can happen is that the drug is not deaggregated, and you get large clumping of powder, and those large clumps simply cannot reach the small airways because of the size, and then you end up getting this deposited in the back of the throat, leading to things like oral thrush and hoarse voice. In terms of being able to reach that, most of the dry powder inhalers need that 60 liters per minute. And then if it's less than that, we think, for example, in young children or older patients or severe COPD or acute flare-up, then the medication may not actually be delivered. So that's the thing to think about in terms of dry powdered inhalers and that minimum peak inspiratory flow that is required. And once we think about the physiology of the patients, we then have to think about the lung anatomy. So in terms of the journey of the drug, in terms of reaching the airways, is really a race against quite a few different mechanisms. So firstly, when the medication goes into the airways, it reaches the upper airway areas. If the particles are too large, as we said, or if you get a really high velocity flow, for example, from a metered dose inhaler without a spacer, then the flow rate may be too high. And again, what happens, it hits the back of the throat and then it just becomes swallowed. If you get the right amount of airway flow, then you can get the appropriate flow into the airways. However, what can happen is if the patient is not coordinating with their breathing, for example, if they're not holding their breath after a metered dose inhaler puff, then what happens is that you can get something called gravitational sedimentation. So the medication just sediments and does not reach the small airways. And then without that breath hold, again, that medication is simply just exhaled. And the most important after that, in terms of anatomy, if you do then reach the small airways, we have to think about, for example, in COPD and asthma, you may get mucus plugging or you may get narrowed airways, and that then can create some drug turbulence, which can cause the particles to crash into the airway walls as well, which also prevents the deficit.
So, Amy, I really like the phrase that you use. It's a race. It's like a race of the aerosol to get into the lungs. And there are so many challenges. And goodness knows how aerosols actually do get into the lungs. You've talked about physiological barriers, anatomical barriers. You've talked about the mucus. You've talked about the narrowing of the airways. And I can just sort of visualize this aerosol desperately trying to get into the lungs to give benefit to our patient. But it's got so many barriers and challenges to overcome. So there's a lot of science and engineering that I think we probably underestimate as clinicians, that the device engineers from the companies and the research and development teams spend years and years trying to get things right for our patients. So, Amy, we get the challenges. Are there interventions that we could do to really top line interventions that we could do to improve inhaler technique?
Absolutely. And there's so many, but, I'll try and summarize these in terms of providing an overview. And one of the key things we have to remember as clinicians is that inhalers have multiple different aspects, and every step can have a significant impact in terms of drug delivery, unlike oral medication. And because there's so many steps, one of the key tools that exist include digital tools. There are many advanced tools out there, quite simply like apps, for example, and checklists that allow patients and clinicians to actually visualize these different steps. So exactly as you said, Omar, there's so many different steps, and it's a race of the particle and aerosol trying to get the airways. And what we can do is map each of those steps with a checklist, for example, or a video that patients then can see and follow along with their clinician. And we can look at that to see how we can visualize the flow of the medication and help provide feedback to the patient. Another really common and useful strategy is to use video recording, and then for patients to video record themselves, and then they can bring this to a clinic on a consultation with their pharmacist, nurse, or their doctor, and they can again go through what errors they may be making, so they can track and provide live feedback to the patient according to what their personal errors might be. There's also some devices as well that can mimic inhaler resistance, for example, an in-check dial. So those of you not familiar with the in-check dial, is you can set different resistances, and then you can mimic the resistance of different devices for the patients again to train on. And most importantly as well, there's spaces that are obviously most important for helping inhaler delivery for metered dose inhalers. But also one of the key things is because as humans and our patients are very, very busy as well, they'll often forget the steps. And as Tonya mentioned, that 70 or 90% of patients will have errors, at least one critical error in the inhaler technique. So having teach back opportunities where you can see and observe what is being done by our patients, being able to feedback and have regular reinforcement is absolutely important. And there's evidence to show that patients often forget as quickly as 24 hours after consultation, they'll forget up to around 50 or 60% of the steps. So every moment that you see the patient could be a therapeutic intervention.
No, that's really helpful. And I was just really reflecting on that and what Tonya said earlier on, and you reiterated it. I mean, Tonya, you said 70% more have problems with their inhaler devices. They have aspects related to the frequency. And then we heard about the race of the aerosol and the challenges. What patients, Tonya, are at risk of poor adherence and compliance? Is there another element that we can try and elicit in the clinic in order to make sure that our patients engage with the device and engage and persist with taking the inhaler medicine?
Thank you for that question. It's an important one because we do know that there are specific subsets of the asthma community that have greater challenges with inhaler adherence. So, first of all, kids and teens. What can we do to ensure that they're repeating those behaviors, that they're becoming more routine? It's oftentimes like using things like their cell phone or their video games as an incentive and a reminder. So, making sure that these routines are embedded in the everyday activities. We often say, like, just before you brush your teeth, for example. That's a good time to remember, or set a reminder on your cell phone. We also find significant issues with the elderly in using inhalers. Now, this is quite different. Sometimes it's honest forgetfulness. Again, if we've got things like early onset dementia or Alzheimer's setting in, it's important to make sure that someone else is checking up on that regimen and reinforcing the right way to use the inhaler time after time after time. With the elderly, we also have to be concerned with dexterity. So, like arthritis and being able to depress that inhaler canister or being able to breathe in a coordinated way to make sure that we're getting the medicine into the lungs. So, there's a lot of specific concerns for both kids, teens, and the elderly that really should be taken into account.
That's really helpful. Having a routine, almost a Pavlovian regimen, as you say, as a mechanism to actually get the patient to engage or at least have the reminder that they need to take their inhaled medicine. And I think you brought the element of just understanding the patient's lifestyle and understanding um, how that lifestyle may dictate their behavior and allow opportunities or not, as the case may be, to engage with the inhalation therapy that they've been prescribed. No, I think that's really helpful. I am going to ask you, Tonya, a little bit about the environmental elements, but I mean, we've always talked about that the greenest inhaler is the one that the patients can use, will use, and now I actually also say has been taught how to use correctly. And I just wanted to show a couple of things and then really ask you, Tonya, for some thoughts about the environment and how we factor that with patients. So we see the ERS position statement on asthma, and the European Respiratory Society put this position statement out on asthma in the environment and the importance of the patient choice to pursue environmentally preferable healthcare. And really what that means is when the whole environment aspect, quite rightly so, was talked about and is talked about, a lot of patients said, do you know what? Our disease is not a lifestyle choice. We have a right to have all the available devices, because what was being proposed in some countries was that you switch from one device to another. And as Amy has highlighted, the pediatric group, the elderly group, those in the acute situation, they may not have the optimal inhalation from powder inhalers where, as Amy described, the turbulent energy needs to come from the lungs to make sure that the device is activated to get the drug in that race into the lungs. So there is an absolute need for metered-dose inhalers. So a lot of patients actually were saying, we have an absolute right to have all the inhalers for us. And the shared decision-making aspect very much was also in the environmental domain. And then I think you see here on this slide in green is it's beyond the right inhaler. It's actually making sure that we've got the diagnosis right. There are regular reviews and correct technique. Sometimes there is overdiagnosis of asthma and COPD, and therefore the patient shouldn't be receiving that treatment. And sometimes there is lack of diagnosis and the patient has asthma, and sometimes they're just given a reliever inhaler, which really shouldn't be the case now. Every patient with asthma should be on a reliever plus maintenance inhaler, either as one device or indeed as a separate devices, anti-inflammatory reliever inhaler. And really, we need to assess, as you said, lifestyle, behavior, and the clinical state of the patient. I think I want to just show this slide, and then I'm going to come back to you, Tonya, is really actually there is a bit of a balance. So if we were to switch, for example, metered-dose inhaler to dry powder inhaler device, what this slide actually shows is that dry powder inhaler devices have a greater plastic burden. So we've got to, I think about the whole planetary health. At the moment, it's not just the skies above our head, but it's also the oceans and the coral reef beneath our feet that are important. And plastics, legislation around plastics has been around for 30 years. Plastic bags now cost money. The data here shows, and you can see that in the orange bars, that dry powder inhalers have a greater plastic burden and have a greater effect on marine life. So it's we might be doing something now, but 20 years down the line, causing an exponential problem because we desperately need our seas for oxygen as well as we need our skies for oxygen. So I think we need to have really a sensible approach to sustainability. So I use that term now, Tonya, sensible sustainability. It's an emotive area, Tonya. If I was to say to you, or Tonya, do you want to protect the environment? You'd absolutely say yes. So how does the environmental factor equate into our discussions with patients, Tonya?
I often say the greenest inhaler is the one that a patient will use consistently and correctly. And so ensuring that we got the inhaler, number one, that the patient prefers, that they can afford, that they desire to use, is first and foremost. The impact on the environment is of concern to most people, patients living with asthma, and yet it's a much lesser concern than keeping themselves healthy and out of hospital, where the majority of the carbon footprint exists.
Oh, that's really clear. Thanks very much, Tonya. It makes us really reflect very clearly in a consultation with our patients. So what I'm actually going to do is, it's been really rich, this discussion. I've learned so much. And what I want to do now, Amy, is for you to give us your top tips, really, an elevator pitch summary from your perspective. And then also, Tonya, from yourself in terms of that shared decision process with our patients. So Amy, top tips really in the clinic that you think, once we've closed this session, we can just go away and do in our clinics or when we see our patients?
I think the first easy takeaway, watch, don't just ask. So asking, often difficult to really work out what our patients are doing. So self-reporting of technique is really not helpful. And we often know there is a confidence gap between where patients really believe they're doing what is correct, or even health professionals believe they know what the steps are, but there are still critical errors. So watch, don't ask. Where possible, ask your patients to demo the technique, demonstrate what they're doing at every visit, using either a placebo device in your clinic or their own device. And my second tip is teach to teach back and teach to goals. So where possible, observe it and then demonstrate what the correct steps should be, and then get the patient to demonstrate it again. You can never reinforce enough. And last but not least, as a patient focus, be patient centered and always continually check, is this still the right inhaler choice for the patient? Are they still managing? We know circumstances change. Patients go through different life circumstances. They also age. Their clinical circumstances change. So we do want to see, is this the right respiratory fit for the patient based on their flow, their cognition, their dexterity? And so those would be probably my top 3 takeaway points.
Brilliant. Tonya, what would you add to what Amy's just said?
So, my key takeaway from this webinar and the conversation is one size never fits all, right? One size does not fit all. We have to consider what is most important to that patient and invite them into a shared decision-making conversation around, is it the environment? Is it the out-of-pocket cost? Is it the simplified regimen? Whatever works best for them is what really we have to tailor the approach to. And it's also not a one and done. We can't teach inhaler technique one time and think that that's it, that the patient's got it. We actually have to reinforce this on every single visit.
I really like the one and done and how that's not what we should do. And also, we need to reinforce the technique. And we need to think about, as you say, the inhaler opportunity. That is, if you've got an inhaler, then we need to have the opportunity just to assess how to use it, because we heard from Amy about inhaler errors. Fabulous, guys. So I'm going to try and wrap everything up and bring this to a close, and I'll come back to you in a minute or two. But at this moment in time, I just want to pause for a second and really ask our audience who've been connecting and listening to us that what is your standard process for routinely checking a patient's inhaler technique? Having heard what we've talked about, maybe the things that we haven't talked about, and your reflections. Amy, Tonya, it's been great. Amy, we heard from you on the main categories of inhaler devices available to us, their key differences you went through with us. You told us about the importance of looking out for inhaler errors and also the impact on our patients. Tonya, you anchored our discussion focusing on the needs of patients and what they want from their inhaler device. And then, Amy, you brought us in to understand the current global recommendations on inhaler use. You gave us some tips on improving patient inhaler technique as well in the clinic. And then Tonya, you gave us some insights into addressing poor adherence. You talked about behavior, lifestyle factors in our patients, and also we touched on being pragmatic for the sake of our patients with respect to their needs for particularly meat dose inhalers, which have propellants, with respect to balanced with protecting the environment. It's been really rich. I've learned so much. I hope you've learned certainly from our experts here. And thank you very much for connecting. And I'd really like to thank very much Amy for your insights, and Tonya also for yours. And thank you very much once again for participating in this activity. Please do continue to answer the questions that follow and complete the evaluation. They really help us to try and improve the offering that you've had today. So thank you all very much.
This program was presented by Medscape Education Global.